this session will be about something that binds all of us together, which is our health. And there is no better time than now to organize this program. We have an important personality who will be leading us in the discussion. He is actually one of us in the sense that he is also a great fair product. I present to you Dr. Adeola Olubunmi Ajibare. Dr. Adeola Olubunmi Ajibare is a consultant physician and cardiologist at Lagos State University Teaching Hospital, Lasut, Ikeja, and a senior lecturer at the Lagos State University College of Medicine, Lasukom, Ikeja, Lagos. He is a 2005 graduate of the prestigious Obafemi Awolowo University, Ile-Ife, where he graduated in the top 5% of his class and later obtained the fellowship of the National Postgraduate Medical College of Nigeria in internal medicine and cardiology, subsequently subspecialty in 2015. He has held many leadership positions and has attended many leadership training and symposia around the world and obtained several certifications, including the leadership certificate from the University of Washington, United States, and several professional certifications from Kenya, Cameroon, United Kingdom, United Arab Emirates, India, Turkey, and so on. Prolific writer, a public speaker, a seasoned academic who has published over 60 papers in local and international peer-reviewed journals. He presently serves as the Deputy Director of Clinical Service and Training Administration in Lagos State University Teaching Hospital, Lasut, and a member of the governing board of the Lagos State Health Facility Accreditation Monitoring Agency, among other responsibilities. He has attended several conferences and symposia, both locally and internationally, where he has presented his scientific and academic works. He is a member of the Nigerian Medical Association, NMA, Nigeria Hypertension Society, NHS, Medical and Dental Consultant Association of Nigeria, MDCAN, Academic Staff Union of University, HASU, among many others. He is happily married with children. Here is the resume of our dear cardiologist. He shall be leading us in the topic prevention of sudden cardiac death. I present to you once again Dr. Adeola Olubunmi Ajibare. So you have the floor, sir. Thank you so much.
Thank you, Revu, for your kind words. For a minute, I did not know you were talking about me. I was looking at myself and I was like, am I the one that they are saying all these big things about? But I appreciate, thank you very much for inviting me. Today we'll be discussing sudden cardiac death. We'll be talking a whole lot about it. I'll do it under the following outline. Sorry, can you hear me? So that I'll be sure that I'm speaking to a class and not to
clearly.
myself. Oh, thank you very much, sir.
Very clearly.
Yes, we can hear you.
Yeah, thank you very much. So this is what I usually introduce some of my topics with. And I'll just cast our mind back to those days that we were boys and girls, that were running all over the place on the streets, we were riding bicycles, running errands. Then we had so much time on our hand and we had so much energy. Many of us would climb trees and go and pluck mangoes, but then we had no money. Then we now transformed from that stage to the stage we are presently in now, that money has started coming in. You have so much energy, people run up and down. Today you are on the island. Tomorrow you're on the mainland. You wake up 4 a.m. You don't get back home until 12 midnight. So there's plenty energy. Money is coming in. But one thing that we tell ourselves is that there's no time. They call you to do this. He said, I don't have time, because you have a whole lot of things that you are doing at the same time. Then the third phase of life is now old age. Then you are retired. You have so much time on your hand. You have made all the money that you want to make. Then at that time, there is no energy. And many people will now be battling illnesses in that old age based on what we do now. So that's why I'm very happy and excited to come now, so that we can talk to ourselves around this age of our lives, so that we can even live long to old age and won't have sudden cardiac death. And when we now get to that old age, not be battling illnesses. So I'm sure that many of us will know Samuel Okparaji, but what many people will not know that he has a master's degree in international law from the University of Rome. What many of us knew was that the man was playing football, national team, he collapsed and he died on the field of play. And you ask yourself that up till that morning, a coach, a responsible coach, is not going to field a player that he feels was not in good health. So up till that morning, Samuel Okparaji was in perfect health, at least so it seems from the surface. Nobody knew what was inside, and he died while playing football. And this one was copied from the Sunday Tribune of 2011. Was a man in Ibadan that arranged a room to have a session with his lover, and he booked the room. He ordered pepper soup, he's drinking. And the truth of the matter is that somebody that feels that he's sick is not likely going to arrange that kind of a match. But unfortunately, man died in active service. And this sudden cardiac death is not a respecter of anybody. They have a very seasoned professor of pathology, a medical doctor, who died at the age of 56 of sudden cardiac death. And many of us will know this story of a very prominent Lagos politician, now Nigerian politician, whose son died of cardiac arrest in London. Also, Islamic clerics are not left out. Some of them have died on the pulpits while delivering Juma lecture. And we know this story on Facebook of a lady in Benin City in Edo State that was dancing during the 60th anniversary of their school. And all of a sudden, the camera was on her. She's sat down on the chair. Before they knew what was happening, they put her in the car. And before she got to the hospital, she was brought in dead. However, at least we got this history that she's a known hypertensive. She had similar illness 3 months ago when she collapsed, and she was said to have been having headaches even on that morning of that she died. So she had the warning signs, and those are some of the things that we'll still be talking about as we go on. Pastors too are not left out. There was this pastor of a particular church that slumped and died on Sunday while delivering the sermon in Onikoko area of Abeokuta in Ogun State. So I got this from the Punch newspaper. So there was a bride, young lady. She slumped and died on her wedding day. There are so many of these, that we can talk about. There was this man that was having, I think it was his 68th birthday too, and he, slumped and he died. So those are just the background. So the question is that what is sudden cardiac death? So it's usually sudden, it's usually rapid, it's unexpected, and unfortunately, is irreversible. So, and most of these things happen within 1 hour of onset of symptoms. Or sometimes we stretch it to 24 hours when we don't even know what happened, because some people, you have to break their door before you find them on the floor and they are dead. So, but one thing I need you to take away from this slide is that it can happen even in the absence of an existing cardiac illness. Somebody may be ill before, they may not be ill before. So that means if you don't check yourself regularly, you don't know what you are harboring. So you may feel that you are fine. Feeling that you are fine doesn't translate to being fine. So when we are now talking about cardiovascular diseases generally, cardiovascular, so it's simply the disease of the heart and the blood vessels. And unfortunately, disease of this axis is the leading cause of death worldwide. And 50% all deaths from heart disease are usually sudden. Unfortunately, almost 90% of these sudden cardiac deaths occur outside the hospital. So most of the time, especially in Nigeria, they don't usually stand a chance because our people are not very knowledgeable in cardiopulmonary resuscitation. So they just carry them, pour water on them, put spoon in their mouth, pour salt in their mouths, and they now start, moving them. By the time they come to the hospital, it's usually BID, which is brought in dead. And unfortunately, almost 18 million people die every year from cardiovascular disease. And even despite Boko Haram, despite war, despite everything, despite famine, despite malaria, cardiovascular disease contributes 31% of all global deaths. So what are the common causes of these deaths? Most of them are usually as a result of complications of hypertension. So what are these complications of hypertension? Heart attack, strokes, heart failure, rupture of the vessels, the major vessel that bring blood out of the heart, which is the aorta, abnormal heartbeats, use of illicit medications, illicit drugs, highly caffeinated drinks, cocaine, heroin, electrolyte imbalance, and disease of the heart muscles that are inherent, whether from birth or that we acquire as we move on with our life, disease of the heart valves, disease of the blood vessels that surrounds the heart, abnormal heartbeats, and blood clot in the leg that occurs as a result of sitting down, prolonged sitting for a very long time. And some of it we even call economy class syndrome. When you sit down for a very long time, you are not moving your legs, blood is not returning back to the heart. There will be pooling of blood in the lower limbs, and stasis of blood will cause clotting of blood. So when the blood clots in the legs and you now move, that blood clot can travel to the heart and stop it. And some people even have congenital heart disease. We all remember the story of Kanu Nwankwo. He's had a hole in the heart since when he was born, but it was not detected until he started playing active football. So that could also, if not checked, it could also cause cardiac death. And finally, and not the least, is family history of sudden cardiac death. So by the time somebody in the family has a sudden cardiac death, every member of that family has to go for proper evaluation to know whether they have something in the family or not. So what are the common culprits that contribute to all these things? Like I said again, hypertension, because we need to say it again and again, again and again. Hypertension is the leading cause of death globally. Unfortunately, it is manageable, it is preventable. And what I tell my patients is that if your blood pressure is high, okay, not a big deal, but it becomes a big deal when your blood pressure is high and you are not doing anything about it. So once your blood pressure is high and you take your medications and the blood pressure is hitting normal values, then you and someone else that is not taking BP medication that have normal values, you have the same risk cardiovascularly. So the big deal is that you are not taking your medications or you are not doing those things that we'll still talk about that will bring down the blood pressure. Stressful lifestyle, excessive use of alcohol, cigarette smoking, obesity, diabetes mellitus, and these days people use a whole lot of illicit drugs, performance enhancing drugs, heroin, cocaine, marijuana, all those things, or even unprescribed medications like steroids, non-steroidal anti-inflammatory agents also make blood pressure to go up. So this slide is just telling us about risk factors for heart disease, and which we now divide into modifiable and non-modifiable. So the non-modifiable ones are the things that you can't do anything about. I mean, that is the risk factors that you just have to live with, like advancing age. As you are getting older, the body is getting older, the blood vessels are getting stiffer, the heart now needs to work harder. So that's a risk factor already. Male gender have more risk compared to female because of the estrogen effect of ladies on their blood vessels. However, after menopause, the risk of male and female will equilibrate. Family history, if it runs in the family, you just have to be very careful. It doesn't necessarily mean that if it runs in the family that you will have it. But if you don't take care of it, it can actually, affect. But those ones you can't do anything about, even if you do gender reassignment. However, the modifiable ones are the ones that we now need to talk about. And some of them include abnormal cholesterol in the body, smoking, diabetes mellitus, hypertension, physical inactivity or sedentary lifestyle. You don't do up to 5,000 steps every day. Ideal thing that everybody should do every day is 8,000 to 10,000. However, by the time you are doing less than 5,000 steps every day, you are sedentary and you have physical inactivity. Overweight and obesity, by the time your body mass index is more than 25, you are overweight. When your body mass index is more than 30, you are obese. And the simple way to calculate this, even in the comfort of our home, is that your body mass index is equal to your weight in kilograms divided by your height in meters multiplied by your height in meters. So that means you are dividing weight divided by square of your height. The weight has to be in kilogram, the height has to be in meters. So at the end of the day, if your BMI is more than 25, you are overweight. If it's above 30, you are obese. And by the time you start eating diets that is high in calories, salt, and fat, those are established risk factors for cardiovascular disease. Then this slide is also further reiterating what I've said, that hypertension is still the leading risk factors for cardiovascular deaths globally, even more than unsafe sex, indoor smoking, and every other thing. So, and it produced more than 17% of global mortality. That's hypertension alone. In year 2000, a quarter of the world population are hypertensive, increased to even almost 60% in 2025. So you see that hypertension is contributing more than half of all cardiovascular deaths and more, up to like half of the burden of diseases of cardiovascular deaths. And this is some of the things that some of us would do. All those things that are behind this wall, the doctor is not seeing. So the doctor is just checking your blood pressure and is just treating blood pressure. This medication is not going to work because there are still other things that are behind the scene. There are still other things like that is causing iceberg phenomenon that you are just seeing. You are just seeing the tip. So the tip is just the blood pressure. But what are the things that is generating the blood pressure? The alcohol that this man is holding in his hand, the cigarette in his mouth, his tummy that is obese, and many other things that he's eating. You will recollect that in the 90s, the televisions were the one that was fat, while the humans were slim. But unfortunately, as from 2019, the television now became slimmer. Maybe they are afraid of sudden cardiac deaths as a result of obesity, and the humans are now very fat. And this is some of the things that is causing the fat. When you make your money and you now say that, yeah, I have to enjoy my money as well. It's not only my family and friends that will be enjoying it. So let me drink 3 bottles of Coke. Let me eat 5 eggs. Let me eat plenty meat and all these things. So what will cause is going to be obesity and eventually hypertension and eventually sudden cardiac death. And many of us are familiar with many of these vices. Those are some of the things that contribute to hypertension and invariably sudden cardiac death. So we did a study in Lasuth Ikeja, went round during the May measurement month. And by the way, May 17th of every year, last week, is World Hypertension Day. And the whole month of May have been dedicated to checking blood pressure. So the whole of May, from 1st of May to the end, last day in May. So we usually move around, check people's blood pressure, advise them on lifestyle changes, and would say that, oh, let's, kick hypertension out of the world collectively. So sometimes in 2019, we went round. So we sampled adults, male socialites in Lagos. And unfortunately, what we found was very staggering and very revealing. So we found out the prevalence of hypertension was about 61.7%. That's 6 out of every 10. Unfortunately, even more than half of them were previously diagnosed hypertensive, but they were not doing anything about it. Found out that 65% of them were obese and 80% of them had abnormal cholesterol. And when cholesterol is there in the blood, in the body, it start depositing inside blood vessels. It occlude these blood vessels and can cause stroke, heart attack, and sudden cardiac death. And many of these people were just moving around with all these risk factors and they were not doing anything. And that's why we labeled that paper, Cardiovascular Risk Factors is a silent epidemic among this group of patients or individuals. So what are these risk factors to also reiterate them again? Overweight, unhealthy diets, alcohol abuse, low physical activity, smoking, stressful lifestyle, some medications I've talked about, steroids, non-steroidal anti-inflammatory agents, marijuana, caffeinated drinks, performance-enhancing medications, some chronic conditions like diabetes, low level of vitamin D, advancing age, family history, male gender up to menopause in women, and people that have borderline blood pressure all along, they need to watch themselves so that the pre-hypertension will not lead to hypertension. So I will now go to the symptoms of cardiovascular disease. Unfortunately, hypertension is a silent killer. So most of the time, there are no symptoms. And unfortunately, by the time symptoms start coming, you start having headaches, you are not sleeping right, your heart is pounding, you walk a little bit, you climb a flight of stairs, you are tired, your legs are swollen, you pee and it's frothy, like foamy, then you are having dizziness, blurring of vision, loss of consciousness, by the time those things are happening, then sudden cardiac death is already knocking because complications is already there. So, and that is why we need to catch it at the asymptomatic stage so that it does not lead to sudden cardiac death. So how do we prevent these things? Because I'm sure that this is the area that we should really sit down and discuss. So the first thing that you need to know is that if you don't check your blood pressure, you will not know that you have elevated blood pressure. So until you check, before you know. So, and many of us, we invest so much money to go and service our car, routine service. The car is not even giving any fault, but you said, I've driven it for 3,000 kilometers, I've driven for 5,000 kilometers. You go there and you change, you buy the best of oil, you buy the best of filter. But what of the body that is making that money? Does he also have that regular health check? Does he have servicing? Does he have change of oil? Those are the things. So you need regular health check. And when you now check and they now identify that there is something wrong, then you need to address it. It's just like you go and scan your car and they tell you that there's something that is making the check engine light to come on. Then address it. And when you address it and you treat those identified ailments, then you go back to brand new. So, and when you now have those things, then you have to be taking your medications for illnesses like hypertension, abnormal cholesterol, diabetes mellitus. Avoid tobacco as much as possible because there's nothing good about it. Even first-hand smoking, second-hand smoking, and there's what we now even call third-hand smoking. And I'm sure that we know about first-hand smoking. The person that is smoking this cigarette is killing himself. Then the second-hand smoking is that people that are seated beside him when he's smoking, they are also benefiting from the diseases that the guy is moving around with. And the third one, which is the third-hand smoking, is that people that were not present when the guy was smoking, they are now benefiting from the harmful effects of that smoking. For example, somebody smoked in a room and he left the room, then somebody now walks into that room much later and he starts inhaling what that guy has smoked. That is third-hand smoking. Somebody smoke, smoking is hanging on his shirt, he goes back home and he hugs his wife and his children, then it's transparent into them. So those are third-hand smoking. So people that were not there when the guy was smoking, they still getting it. So you avoid tobacco as much as possible, level of alcohol as much as possible. You do lifestyle changes, you do cardiovascular risk prevention by what? Regular exercise, healthy eating, healthy living, low salt diet. Then exercise can now be adapted to whatever you are doing. Like you can do something that will be fun. You can dance, you can cycle, you can swim. So it doesn't really have to be that I need to get to the gym before I do all those things. Then, of course, you have to create time to rest and you have to create time to, just relax and have vacation from time to time. Because I know that many of us, even when they give you leave 1 month, you still use that leave to go and work in another place so that you can make extra money. Just remember that my slide I said, you need to create time for yourself so that the illness will not create time for you in old age. And above all, we should not ignore warning signs. Most people are not lucky to have them. You remember that lady that I cropped that stuff from Facebook, that she had warning signs, but she still went on and still was dancing, jacking up her blood pressure, and she was not taking BP medication even at the 60th anniversary of her school. So what are those lifestyle modifications I'm talking about? So reduction of weight. If you reduce your weight by about 10 kg, you're going to bring down your blood pressure up to about 20 millimeters of mercury. So DASH diet. DASH diet means dietary approach to stopping hypertension, which include consume diets rich in fruit, vegetables, low fat, low milk, low cholesterol, can reduce your blood pressure about 14 millimeters of mercury. If you cut down on your salt intake, you don't add salt on the table, just take very minimal salt in your food, you can reduce your blood pressure as much as 8 millimeters of mercury. Engaging in regular aerobic physical activities, about 30 minutes every day, most days of the week, can bring down your blood pressure up to like about 10 millimeters of mercury, and cutting down alcohol can bring down your blood pressure up about 4 millimeters of mercury. So why do we need to do regular checkup? So because most illnesses usually start small, usually start asymptomatically. So if you do a regular check this year, by next year, if you are doing it again, if anything is flagged, it means that that thing has been there within 1 year. However, if you have not done medical checkup all your life and you are now 45 and you are now doing one now and you are now picking something, that thing may have been incubating there for 20 years. And the earlier you catch it, the better it gets sorted out, because there are some people that by the time you catch them, they are already presenting late, the symptoms are already florid, then there is little or nothing that you'll be able to do about it. Another reason why you should do is that all body parts, they age as we grow. I mean, you are not likely going to use a tire for 5 years. You are not likely going to use engine oil for 2 years. You are not likely going to use some of the components of your car. So our bodies also grow old. Your hair becomes gray, your skin becomes wrinkled. So internal organs too, they will also suffer the same fate. So if you detect abnormalities early, you can treat them early and you can correct them early. Then there are some people that have abnormal body variation. That's who they are. So you do their ECG when they are 10, it's the same abnormality that you find when they are 70. So those ones, the doctor is not picking it for the first time and rushing to go and treat. I have some patients that they have some abnormality and I will tell them, no, don't worry. This one is is how your body is. So we don't need to be running up and down. So, and of course, if you pick an abnormality that we know that it runs in family, you can warn other members of the family in case that thing runs in your family. So how often should we do our checkup? So the answer is that as need be. So that's the thing, because it's not age bound, depending on what we find. But however, generally, if you are under 30 years, of course, I know that most people here are more than 30, but we have families and friends, we have children, we have younger ones, we have cousins, we have other family members that are less. So if you are under 30 years, you are recommended to do your general checkup every 2 years. However, by the time you hit 30 and you are older, you should do yearly health screening. Depending on whether you are a male or female, there are so many other things that you can do. I'll still talk about them. However, for those over 50 years, you have to do more age-related screening tests. For example, now, a man under 30, I'm not going to recommend that he does a PSA. But however, by the time you are 40 and above, you should start doing PSAs and all that. So you have to do more age-related screening tests. And when we pick an abnormality, depending on what the abnormality is, your checkup can be as frequent as monthly, because we want to use it to monitor, we want to use it to treat, and we want to use it to follow up on your care. So what are the examples of tests that we need to do? So do your blood pressure regularly. And the campaign now is that every household must have at least one blood pressure machine in their house. That's the campaign. So check your blood pressure as need be. Anybody comes to your house, before you give them Coke and Fanta, just encourage them to check their blood pressure. That is a better gift than even giving them anything that you want to give them, like food. So you can do your blood count, you can check your cholesterol, you can do your diabetes screening, because a whole lot of people, by the time normal fasting blood sugar is between 3 to 6 millimoles per liter, to get somebody in the hospital that is coming for the first time diagnosing diabetes mellitus, and you are seeing blood sugar as high as 22 millimoles per liter, and you now look at how did this man get to this point? He did not get there in a day. He did actually not get there in months. So the guy has been building up on his blood sugar over the years, and he refused to check. So kidney screening, cardiac screening, prostate cancer tests for women, mammograms and pap smear, liver function tests, colorectal cancer screen. Those are general things that we just need to do as need be. But from the little experience I've had, I mean, these are some of the excuses that people say. I'm not sick. But the question is that must you be sick before you check whether you have something that you are incubating, or I don't have money. And many times you now ask them that, oh, prevention, I heard that is cheaper than cure. So, and it's even better than cure. So why don't you just look for the money to prevent disease and to now be using to cure advanced disease? Say it's too expensive. And the question is that, what exactly is the cost? Most of the people that will say it's too expensive, you ask them, how much is it? They don't even know. So they said hospitals are too far away from me. I'm too busy. I have, and you know, the answer is already in that first slide. You can be too busy, but it's how you lay your bed. That's how you lie on top of it. And you will understand that the burden of healthcare and doctors is as bad as this picture. And since prevention is better than cure, don't just add to the existing healthcare burden that we have in the country. So take care of yourself. And as I conclude, I want to say that you should take care of yourself, because if you don't do it, there's no one that will do it for you. And you will definitely be replaced immediately you become unproductive or die. I've seen it happen many times again and again. Somebody does not show up for work, that work will not close. Somebody doesn't show up for work because of illness or death, branch of bank, that branch of hospital, that branch of company will still function effectively that day. And prevention is cheaper, easier, and better than cure. I want to conclude by saying that you are precious to your family and friends. So you should stay alive and stay healthy so that you don't do crowdfunding for hemodialysis or for burial. Thank you very much for having me.
Wow, wow, wow. That's all I can say. Thank you so much, Doc, for your time, for the loaded message, well researched, and excellently delivered. We thank you so much. People are already clapping. They are using their, signs to clap and to say thank you so much for your time. Um, I know that a lot of us will have one or two things to ask, uh, or even to add based on personal experience, because the essence of this meeting is also to share ideas, including those who are dealing with something and maybe they have managed it well and they wish to also share it with us on the things that they have done. And if you have direct questions to for the doctor on some of the things that he touched, the floor is now very open. Just as I said, thank you so much for the presentation. So, guys, the floor is open for contributions and questions from all quarters. Let me see whether people have started raising hands. If you want to ask questions, you can notify by raising your hand. Is there any hand raised here? Hello, can you all hear me?
Yes, now
Hello?
Olivo.
Oh, okay,
Can
okay.
hear you, sir.
We can hear you.
David Oladokun, you have the floor.
Yes. Yeah.
David.
Good evening, friends.
Yeah.
And thank you for the lecture.
Good evening.
It was, in fact, it was a well delivered lecture. In fact, I won't say lecture per se. I will say it's a teaching. Okay. Now, can we relate atmospheric condition to cardiovascular disease? Is it possible? Hello?
Sorry, I think you are breaking. Hello?
Hello, I'm hearing you clearly.
Yeah,
Hello,
I had him.
Dokun, yeah. Can you repeat? Fire on, please.
Okay, can you relate atmospheric condition or weather condition to cardiovascular disease?
Okay, that's your question. Okay.
Okay, thank you.
Thank you so much.
I'll just note all the questions so that we can treat everything together.
Okay, thank you.
Answer them at once. Okay. Thank you, Dokun. The floor is still open. You can unmute and ask your question directly.
Okay, good evening, everyone, and good evening, Doctor. Thank you very much
Good evening.
for the lecture. The question I want to ask, which is related to what David asked,
Okay. Your
is
name?
apart from environment. Okay, my name is Adekunle Yusuf. All right. Should I go ahead?
Yeah, you can go ahead. What's the name?
Adekunle Yusuf.
Yeah. Okay, Adekunle Yusuf. Fire on.
Yes. Okay, thank you. So the question I want to ask, which is related to what David asked, is
you have the floor.
Apart from environmental condition, what of characteristics like right? Because I don't know how true is this that Black people are more predisposed, have more risk, are more predisposed to cardiac disease than white counterparts. Is race a risk factor to having cardiovascular disease? Thank you.
Okay. Thank you so much. Well noted.
Hello.
Yeah, the floor is still open. Hello.
Okay, yeah. So, so I want to know. This is Jide. Yeah. So I want to know, right? Is it the question? Is it only related to only cardiovascular diseases, or we could also ask other questions, like maybe prostate cancer? You know, the causes, the prevention, you know, things in that regard. Or we have to only streamline it to your topic.
Okay, I think you can ask anything really. So I would treat it as much as I can and refer you appropriately if it's something that is more deeper.
Okay.
So I think you can ask.
Did you hear it? Because it was breaking at it. Okay. Sorry.
Yeah, I had him. Yes, I had him loud and clear. It was yes, it was very clear.
Thank you so much. Yeah, the floor is still open. Yeah, thank you. The floor is still open. You can unmute and ask your question directly.
Okay, so maybe I should just take the ones that while we are waiting, maybe I should just take some of these ones that they are already here. So the first question was that atmospheric conditions, can they cause adverse cardiovascular problems? Oh, yes. So the answer is yes. And let me just mention a few, one of them. So extreme of temperatures have been shown to cause, to affect blood pressure generally. For example, when you have very high temperature, you sweat more, you are dehydrated more. And if some of the medications that you are using for your blood pressure is a diuretic, diuretics are some of those medications that make you to pee, and they are very useful when it comes to managing hypertension in the blacks, which will still relate to the next question about race and risk factors. So maybe I should just finish this one before I now talk about that. So when you are taking diuretics, you are losing fluid. Extreme of temperature will make you lose more fluid because you are going to sweat. So you can be dehydrated. And dehydration can lead to abnormal heartbeats, which we call arrhythmias. And arrhythmias are precursors for strokes and heart attacks. So that's why generally, even if you are not taking BP medications or you are taking it, you should, stay hydrated and improve your hydration level at all times. Then other things, that we can relate to atmospheric condition, air pollution that would affect the lungs, and disease of the lungs would definitely affect the heart. Number one, that the heart pumps blood directly to the lungs through the pulmonary arteries. Then number two, both of them are together in the chest. They are neighbors, they are contiguous organs. So when there is abnormalities that is affecting the lungs, they also affect the heart and make it worse. And also, extreme of temperature, dehydration will cause high viscosity of blood, just like low humidity too will. So all these ones can contribute towards cardiovascular disease. So the answer is yes. So when it now comes to race and cardiovascular risk factor, okay, so Caucasians and blacks, they have different pathophysiology, a little bit of different pathophysiology when it comes to blood pressure. So the hypertension of blacks are more volume driven. So the heart is pumping a whole lot of blood. The heart is now getting strained as a result of volume. That is why diuretics will respond better to diuretics, which is something that will keep down the blood volume compared to Caucasians that their home blood pressure is more of pressure dependent, while our own is volume dependent. And that is why many times I still tell people that it is only blacks that can manage, our blood pressure better than, because Oyibos will give their guidelines and predominantly for Caucasian. We will also give our guidelines predominantly for our blacks. So our blood pressure is more volume and salt driven compared to the Oyibos that their own is pressure driven. Yes, we used to also think that Oyibos have more of heart attacks, but we have now realized that, westernization of our diet and our lifestyle is also making us blacks to also have more incidents of heart attack and all that. Or maybe now that we have more equipment to make diagnosis, we are seeing a whole lot of more heart attacks in black population. And the last question is about prostate cancer. Oh yeah. So the thing about prostate CA is that, just like I mentioned earlier, so by the time you have 40 and above, you should take yearly PSA. PSA is a prostate specific antigen, and normally it's supposed to be less than 4. So if you take it and you are less than 4, then that means the risk of prostate cancer is very low. So if it's between 4 and 10, it's neither here nor there. You may need to take further investigations. By the time your PSA is 10 and above, then you also need to see a urologist as a matter of urgency so that they can, take a biopsy, identify what exactly is going on in your prostate gland and all that. However, at this point, I now need to say that every man, as you are getting older, by the time you start having gray hair, your prostate is getting bigger. So, but it's not all prostate that is big that is cancerous. So there's something called benign prostatic hypertrophy, BPH. So that is normal enlargement of prostate that comes with age. So all prostate will get bigger. But it now only becomes problematic if your prostate is now compressing on the urethra and you are now finding it difficult to pee. Or you are now getting to the toilet, you want to pee, then you now finish peeing, then you are now going, then you now have feeling of incomplete bladder emptying, and the urine is still dripping at the end, it's terminal dripping, and you are now staining your trousers and all that. Then that means your prostate is already causing problems for you. Although it may not be malignant, even if you do your PSA and your PSA is less than 4, but you're having symptoms of prostatism, like you get there, it's not coming out fully, it comes out, it's still looking as if it's remaining, or it's not feeling like it's remaining, but the thing is dropping after you have put your distance inside your distance. So then you now know that it's time to see a urologist. I don't know if I've answered all the questions or if there are other questions so that we can take it.
Okay, thank you so much. Well, I think Adeleke Olashade is still raising her hand.
Okay, yes, I think I saw a question. How can someone achieve 5,000 steps a day, especially if you have a temporary disability that can't make you move around? Okay, so it's difficult, and by the time we see this kind of situation, it's usually a vicious cycle. Because the problem is, okay, for example, now I have somebody that was sedentary, so he became obese. When he became obese, he now started having arthritis of the knees, and you now you have that obesity, it's already causing arthritis. Then at that point, if you want to do vigorous exercise, it's going to cause more problem on that knee. If he does not do the exercise, he's going to get more obese. And I think that's now why obesity is gradually being classified as a disease entity on its own. And that is why there are now some weight loss medications that are now, being pushed in the markets. Yeah. So if somebody has temporary disability, I think maybe dancing will help, because some of those exercises that are good, like I said, are dancing, brisk walking. If there is disability, walking may not be it, but maybe dancing. Of course, cycling will be off it again. Maybe swimming as well. So those are some of the things that. Then, if the big problem is obesity, then you can use GLPs to cut down on the weight. I don't know if I've answered that one as well.
Sorry, what is GLC? Sorry.
Oh, okay.
Thank you. Yes, sir.
Okay, so GLPs, GLP-1, those are the new medications.
Okay.
Yes, those are the new medications now that
Okay.
that many of our Instagram people are using to lose weight. So what they do is that it's like a once weekly injection, you take it, then it cut down, you start reducing it works on your appetite center. So you are not even feeling hungry. Then it reduces gastric motility. So whatever you eat is going to stay there for a very long time. So if you are not eating, you can't gain weight. So those are shortcuts to losing weight that is now readily available. It's a little bit expensive, but the generics are now available.
Or is it LD? Sorry to.
Well,
is it LD?
So far so good. So now this is how it is. So the GLPs, they were initially manufactured to control blood sugar. They were blood sugar reduction medications. However, like many medications in medicine, there's something called drug repurposing. For example, now like tadalafil that they use for erectile function. It wasn't ab initio a medication for erectile dysfunction. It was ab initio a medication to treat pulmonary hypertension. They now realized that people were coming back for it more and more, even when they don't have pulmonary hypertension. So that they have this erectile. So it was repurposed for erectile dysfunction. So the same thing with GLPs. They were originally ab initio blood sugar reduction agents. But they now realize that people that are taking it, they are no longer hungry, their gastric motility is low and all that. But the thing about any medication that you want to use to reduce blood sugar, because if you are reducing blood sugar, most diabetic patients don't even die from the blood sugar, they die from cardiovascular disease. So what you want to do is that you want to test that medication, whether it has cardiovascular side effects. So the GLPs, when they were tested for cardiovascular side effects, they had no cardiovascular side effects. So that one has already been tested. However, other things is only time that can tell. So medications come into the market, you do phase 4 clinical trials, which is called post-marketing survey. Then you watch them over the next 10 years, report adverse effects. If there are none, then you leave them there. If there are cardiovascular, there are other side effects, then you start recalling the medication. But so far, so good. No major adverse cardiovascular or otherwise side effects has been seen with GLPs.
Thank you so much. Okay, the floor is still open. Do we have any other person who has something to ask?
Someone is raising his hand.
I thought you had already they've answered your question now. Any other thing? Dokun? Okay, you have removed I put the hand down.
Okay, thank you, Evo. Hello.
Oh, okay. You have the floor.
Evo. Yeah, okay, thank you. Doc, please, let me take you back to the time of Corona. There was two guys. There were two guys. One in Canada, the other one was in America. So they were chatting. The one in America now asked, Corona, he told his friend that Corona virus killed them more than the way it affected the Africans. He now asked why. The one in Canada now replied in and said they were monsters. Was it not funny? So I now want to ask what happened, because the coronavirus affected them more than we in Africa. What happened?
Okay, so I don't think there will be one straightforward answer to that. There are so many theories that were raised then, and one of the theory was that okay, so let me come from the back and move, from the front and move slowly to the back. And this was the thing. So one of the medications that were tried, Corona hit everybody, nobody was prepared and all that. So everybody was just trying everything. So one of the medication that was tried during Corona was chloroquine. And we tried chloroquine, we tried hydroxychloroquine. And they discovered that some people that were given chloroquine, they had some results. And there was this medication too that we used to treat schistosomiasis. I've forgotten the name of the medication. That too was tried during coronavirus, and some people got results. So some of the theories that people now propounded then, looking at hindsight, which is always a perfect vision, was that Africans were more exposed to chloroquine in the past, and Africans were more exposed to that medication for schistosomiasis also in the past. So maybe that was what conferred us some level of less severity of the symptoms. Because, we had Corona too, just like Oyinbo's had, but many people had it and the symptoms were not as severe as that of the Oyinbo's, because most of them, their lungs was just messed up. The moment the Corona enters their body, within a short time, the lungs was shut down and all that. So, but we didn't have, of course, we had some deaths. We didn't have as much death as the Oyinbo's had, and So there are so many things that were advocated, but it's not because we are monsters anyway. I mean, we have the same number of chromosomes with them, some little differences in our physiology. Structurally, we are the same. So it may be as a result of some of the exposures to medication. Another one was sunlight. So some people said high level of vitamin D conferred immunity. Sunlight attenuated the viruses. There are so many theories that were given. So, of course, one of them is not that we are monsters. Thank you, sir.
Thank you, bro. God bless you.
Thank you so much.
Thank you.
Yes, sir.
God bless you.
Okay. At this point, in the absence of no other questions or inquiry from anybody, can we, excuse the consultant cardiologist who has done wonderfully well, not only for his presentation, but also answering the questions that were asked by the participants. Dr. Ajibare, we thank you so much for your time, for your patience, and for answering us. We thank you for your time, and it's like coming back home to come and share ideas with fellow Great Ife. We really appreciate you. We'll also share your contacts, direct contacts. Some might have reasons to contact you directly. We'll share it with our members who might have one reason or the other to reach out to you personally. Thank you so much. We appreciate you. Thank you so much, Doctor, once again. We appreciate you, sir.
Thank you very much. Thank you for inviting me. Thanks. Yeah, I wish you all the best.
Yeah, thank you.